When I say that, what I mean is it's not a long one. Morning to everybody on Zoom as well. Don't stress yourselves out. I'm not going to like hassle you all with questions and all of that. We're just going to go through everything. All right. Those of you joining us on Zoom, sorry for the late start. A bit cold this morning. Couldn't really get going. All right. So we're going to cover one ECG today. And yeah, let's see. All right. So we've got a 59-year-old man who presents with dyspnea, cough, hypoxia. All right. Now, anyway, beyond all of that, the first thing that we always do, we analyze axis, then rhythm, then rate, then we analyze each zone and things like that. But always, you know what I say, ECG is not done in isolation. All right. We always do an ECG in terms of the actual patient. All right. So, let's start. What do you guys think? I mean, like I always use that example. You know, you're sitting in your car, and somebody phones you who's junior to you, and they give you this example. All right. So you got a 59-year-old man, presents with dyspnea, cough, hypoxia. All right. Are you rushing to go and do an ECG? No, you're not rushing to do an ECG. So what's your differentials on this patient? Firstly, simple stuff. What would you consider? Patient who's dyspneic, coughing, and hypoxic. All right, so their sats are low, they've already got a cough, and they're breathing at a rapid rate. It's simple. What are your differentials in terms of something like that? Okay. Yeah, pre-existing conditions. You know, it could be a COPD patient, an asthmatic patient, could be something like that. But what else? So it could be an infective cause, a non-infective cause. All right. So what would be your infective causes? Yeah, TB, LRTIs, in this day and age, COVID, things like that, right? So you'd already be thinking of all of those things, okay? Even before you actually saw the patient, okay? So those would be your first, sorry about that. Those would be your first differentials, all right? So that would be any of your infective causes. Non-infective causes, COPD, asthma, CCF, considering the age, 59-year-old man, you know, anything else that you can think of? Tumor, you know, is this a new CA lung, is this something else? Obstruction, is there airway obstruction, you know, things like that. So you'll go through all of that. So actually the ECG will not be at the top of your list. Morning. How's everybody? Morning. How are you? All right. Okay. Nice to meet you. No problem. Come have a seat. All right. So, like we say, your ECG is not the top priority. All right. But let's just say you do end up getting the patient, you have a look, your patient's got SATs of 67, for example. Your COVID swab comes back negative. All right. Your patient's X-ray looks weird, and the physician says, okay, we're going to admit to ICU, for example. All right. Now you need to do an ECG. All right. That's probably the first time you do an ECG on this patient. All right. But nevertheless, here's your ECG. What are you going to do? Because it doesn't look like a normal ECG, agree? Something just looks a bit weird over there. So the question you're going to ask ourselves is, what looks weird? All right, because now before the patient goes to ICU to get treated for a severe pneumonia, what if we are missing out something else, all right? So that's what we're going to be looking at, all right? So the first thing we're going to have a look at is the axis. Does anybody here remember how to do the axis? Shall I do it for you? Very good. Very good. So we look at lead one in AVF. Let's just draw it out over there. Let me get the annotations going. Sorry. So let's just do it like how we do it every time. So that's our little grid. All right. So for axis, normal, left, extreme right, and right. Okay. Sorry, somebody was saying something on Zoom. Couldn't hear you. Welcome to say it again. All right. Anyway. Might have been a mistake. All right. So we know lead one is positive. All right. So that means the electricity is moving towards it there. All right. So we know we've either got a left axis or a normal axis. Okay. So which one will give us a clue? We've got to look at AVF. And AVF is pointing up or down. What do you think? Okay. Pointing downwards, eh? Yeah, it's mainly pointing downwards, right? Or you could say even biphasic if you want to be technical. But if you really look at it, the majority of it is pointing down, right? So if this is AVF at the bottom, that means electricity is moving away from it, either in that direction, All right, so remember, you can use any method you want. I'm just showing you a simple one, right? So we know we have a left-sided axis. Okay, so at least we've got that part out of the way. All right. Okay, sorry. See, somebody trying to in. Okay, sorry. But it just got very poor reception there. It keeps on going off, joining in again. All right. Dr. Beko, sorry, I had to mute you. We could just hear everything that was happening. All right. Okay, so we know that. Now let's look at the rhythm. Okay, so the first thing we're going to have a look at is we're going to have a look at the P waves. All right. So let's have a look at our P waves. First of all, where can we see P waves? Let's look for them. Not really. Maybe one or two there, one there. This looks like an odd one there. But all right, let's look at it. All right, so here we've got the most normal looking P waves, all right, in lead 3. But if we were to look at lead 2, where we would normally get a rhythm strip, does that look like a normal P wave? Not at all, isn't it? In fact, the P waves look a bit weird over there. Agreed. They look almost biphasic. Agreed. All right, so we know P waves are not normal in morphology. Does anybody know what this type of P wave is called? Okay, we'll get to it just now, don't worry. Let's say the one in V1, or even in V2, or even in lead 2. It looks similar to P metron. All right. But anyway, we'll get into that. I'm not going to stress too much about P wave morphology in this meeting, but anyway. But the most important thing, we know it doesn't look right. Okay. Oh, somebody's got an answer. Okay, let's see. Biphasic. Yeah, that's 100% right. Biphasic. Okay. So anyway, we'll get into P metralis and P pulmonalis at another stage, but I'm not going to stress too much about it right now. All right, let's look at our PR distance. All right, so we've got, let's take this one. It's the easiest one to measure. So 1, 2, 3, 4, 5, 6. So quite a big PR interval. All right, so that means from the time of the atrium contracting to the ventricle contracting is prolonged. So that's called a first degree heart block. Okay, so first degree heart blocks can be of some consequence, may not be of any consequences. Right? It can be a normal finding. Okay, but we know we've got a first degree heart block. Our QRS complex, are they narrow or wide? A tough one, yeah? Here they look wide, here they look narrow. Great, so where do they look wide? In V1 and V2, right? And V1 and V2, look at which part of the heart? The right side, the left side? Considering they sit here, the heart sits like that. The right ventricle is more towards the front, the left ventricle more towards the back. They look more at the right ventricle, all right? So if they are wide here, that implies sort of like a block. So what do you think? You got a right bundle or left bundle? Considering they're looking at the right-hand side. Come on, you got a 50% chance of being right. Right bundle, and looking at this, does it look like a complete block or a partial block? Considering it's sort of there, but not really there. Would that be complete or incomplete? Incomplete, very good. All right, whereas a complete bundle branch block would probably be easier to see than an incomplete part. All right, now I'm not going into the morphology. I'm just giving you an examples of how you can think it out. All right, so we know we've got already some issues, right? But that's why it thins out here. They're a little bit narrow, even though they borderline here. But we say we've got more of a right bundle branch block than a left bundle. Okay, right. Does a QRS follow every P? It does. So every you've got a P wave, you do have a QRS complex, even though it's a bit widened. Are they regular? Yes, they are. Our P waves occur regularly, our QRS complexes occur regularly, even though they're not 100% normal. Okay, so we already know something's happening on that right side of the heart. That's not 100% okay. We know we've got a left-sided axis. So a left-sided axis tells us what? Either the left side has become bigger or there's damage to the right-hand side. So that's why electricity is going to the left. Right? So we know something's happening in that right. Okay. All right. What's the next part of it? Let's look at the rate. The rate we've got, let's see from here, 1, 2, 3, 4, 4.5, 5. So we're getting to about 70 beats, 68 beats per minute. Right? So it's relatively normal. It's not a brady, it's not a techie. Right. Now let's look at each zone. Okay, so let's start with the inferior zone. What do we see? Anything abnormal? Money. Does it look okay? Does it look like what you used to see? That's the first thing. Not really. What looks odd about it? That's what you got to ask yourself. So start first. We know the P waves here don't look normal. What about the QRS complexes themselves? Are they normally this small? No, they're normally a little bit larger, isn't it? So what would make them small? What do you think? Remember, ECG is measuring electricity, right? So it's one of two possibilities. Number one, your heart is not making enough electricity. Or number two, it's making enough electricity, but it's not reaching the leads, right? So if your heart's not making enough electricity, you're going to die, right? So the more likely answer is there's something blocking it from getting to the leads themselves. So what can block it? Directly around the heart, you could have fluid. Around the lungs, you could have fluid or disease. Around the body, you could have fluid, fat, what else? Clothing, incorrect placement. There's a lot of things that could. What if you put them all on the bones? All your leads are sitting on bones that can't conduct electricity well. So this is what you got to think of. But considering our patient, dyspnea, cough, and hypoxia, what's more likely? We haven't seen this patient. What do you think? Either pulmonary, all right, or in the body itself. So where would you be leaning to? What could happen around the lungs? We said fluid. What's fluid around the lungs called? It's an effusion in the pleura, which is called a pleural effusion. Very good. You guys are practically pulmonologists. Excellent. Right. And what do we call fluid in the body? Edema. Very good. So this patient could be edema. You look at me like I'm crazy. But it's true. Isn't it? We just got to reason it out. So our patient could have CCF. Our patient could have pleural effusion. Alternatively, could have disease of the lung. All right. Fibrotic disease of the lung. Anything that's preventing electricity from moving. Right. So we haven't seen this going on. Hello?
How are you? Good.
All right. I think somebody's just talking. Hi, Dr. Ricardo. Sorry.
I have to go today to the clinics, so I need transport if it's possible.
Okay. I don't think we can arrange that from Madideni, so I'm going to mute you in the meantime. Sorry. All right. Pericarditis. So the pericarditis is an inflammation. It does lead to changes, but we've discussed it before. It doesn't generally lead to small QRS complexes, right? And then the last part is our T waves. How do our T waves look? Can we see T waves anyway? Not really, isn't it? They're flat, they're not showing too well. But that could be because there's not enough electricity passing to the leads. So it's difficult to say from these ones, right? Let's go to V1 and V2. What do we see? We see what we saw. Incomplete right bundle branch block. What else do we see? Considering this is let me just annotate this here. I'm not giving you the answer. We're just trying to figure out. So considering this is the baseline, all right, what do you see there? Just there, that little, could there be a little ST elevation? We're just trying to figure out what's going on, right? It could be here as well, though not as pronounced. It's not pronounced, but there is something that's going on, all right? We know our P waves don't look well. We've got this incomplete right bundle branch block. ST elevations, specifically if they occur in V1 and V2, can occur normally, but it is not something that you should just ignore either, right? And what about our T waves again? What do we see? Can't really see our T waves, agreed. So something's happening, the patient's not repolarizing properly, whatever it may be. Let's look at V3, V4. What do we notice? Anything odd? Got this RS pattern. Again, the T waves are not really showing up too well. In fact, the T waves are inverted here as well. Agreed? They are. What about V5 and V6? Now we're looking at the lateral side of the heart. What do we see? Again, we see those T wave inversions, and leads 1 and AVL, which is also the lateral side of the heart. What do we see? Again, those poor QRS complexes, so what do you call that? That's called poor R wave progression, isn't it? So there's poor R wave progression. So there's quite a few reasons for that. And then we see these T wave inversions and things like that. On AVR as well, we just see this evidence of a right bundle branch block. So we've got a whole lot of things, nothing specific. Agreed. So in other words, we'd have to tie this to what we're seeing in the patient. Agreed. And we'd have to marry the two. But just looking at our ECG, what would you be worried about? CCF, LRTIs, pleural effusions, not so much pericardial effusions because they look a bit different. We'd be worried about right heart as well. Agreed. So we've got quite a few differentials. All right. So how are you going to investigate this patient? That's the question. Are you going to do enzymes in this patient? I would. I mean, I'm not going to stress about them, but I would do them, you know, because we've got this whole lot of T-wave inversions and things like that. Are there any other diagnoses we haven't considered maybe that could possibly fit into this? Something else that can give you dyspnea, cough, and hypoxia? Could an embolus cause that as well? Yeah, pulmonary embolus could definitely cause it. Does the patient have signs of pulmonary embolus? Okay, he's not tachycardic, but he is 59 years old as well. Could have primary cardiac disease that we don't know about. He's got widespread T-wave inversions and flattenings. He's got an incomplete right bundle branch block. He's got evidence of a T metrale over there. So there's quite a bit that's going on, you know. So would we be able to, or would we be shot at if we took D-dimers? Nobody would shoot us. Agreed. If you take D-dimers for somebody with a broken toe, people will come and ask you, what the hell are you doing? But if you did D-dimers for this patient, nobody would say no. Right? And remember, this is a very sick patient. You know, you're not, this is not somebody who you're just admitting to the ward, you know. Or if this patient was going, let's say, for instance, to COVID ICU, you'd still look at all these things. Agreed. So that's what we're just trying to pick out. So we're just trying to look at all of that. Now let's have a look at the answer. So we got quite a bit. I have no idea whether we're right or not. I did this a long time ago. I can't remember the answer. I'm hoping we're right. Okay, so let's have a look. So we've got a sinus rhythm, rate of 733. We are more or less okay. Left atrial enlargement. Okay. Poor R wave progression, T wave abnormality consistent with lateral ischemia, non-specific T wave flattening in inferior leads and low voltage. Okay. So LAE is equal to left atrial enlargement. PRWP is poor R wave progression. Okay, so this is, I wanted to pick this one out just to show you guys that sometimes you can't get an answer. There's not much here. We just know something is wrong. Do you get what I'm saying? So sometimes what it means, it just has to guide us into what other investigations we need to do. Okay, so let's have a look at this. So what does poor R wave progression mean? So it's R wave amplitude in lead V3 of less than 3 millimeters, all right? It's suggestive of a previous anteroseptal MI, all right? Although in this case, it was a normal variant. So it doesn't really tell you much either, agreed? So it can be normal, but it can be abnormal. That's the thing that you need to look at. So in other words, if you have these R waves that are just not going up, they're just not going up. For example, they're just remaining small, but your patient doesn't have edema, your patient doesn't have a pleural effusion, your patient doesn't have evidence of a pericardial effusion or severe lung disease, would you then consider ischemia? Yes, right? Because remember we said there's two reasons that the patient has low voltage. The one is everything outside of the heart and then the heart itself. So if you consider everything outside of the heart and you've excluded it, the only thing left is the heart. And what causes the heart to have less electricity? It's been damaged. What causes damage? Ischemia. All right. In rarer cases, trauma, infection, so on and so forth. But the most common is ischemia. All right. Low voltage is present, defined when the amplitudes of the QRS complex in all these, you look at it. All right. If you can remember all of this, great for you. All right. Use your intellect. Look at your ECG and compare it to when you've seen normal ECGs. You're not trying to become a cardiologist. Remember that. You're trying to pick out things that you can look at. So even if you are not a cardiologist and you look at this ECG, you can have a look and say, you know what, this doesn't look right. Those RAs, those QRS complexes, let's not even say RAs, QRS complexes look small. All right. I'm going to look at the rest of the body and then I'm going to look at the heart and try and decide what's going on. All right. So what are the differential diagnoses for low voltage? Mixed edema, edema. All right. Large pericardial effusion, large pleural effusion, end-stage cardiomyopathy, I forgot about that. Severe COPD, severe obesity, infiltrated myocardial diseases, constrictive pericarditis, prior massive MI. Okay, so there's a whole lot of differentials as to why you could take it, all right? The patient in this case had severe edema. Emphysema, sorry. Severe emphysema, all right? So does the severe emphysema explain what we were seeing in the patient? Dyspnea, cough, and hypoxia. It does, isn't it? It does. This was a patient with severe emphysema, COPD, presents with an acute exacerbation. It's not a primary cardiac disease. However, we were just saying, giving an example of this patient going to ICU. That's why we did the ECG. So that's why we're having a look at it, all right? But what it means is that when your patient goes to ICU, you have now added on my extras. I've added on my cardiac enzymes because I'm worried. Is this an ischemia as well? And there's quite a bit to say that it is possible that it could be ischemia. Have I looked at an embolus? Yes, I have. I've tried to exclude because there is, I mean, anytime you get these T-wave flattenings and inversions, you've got to think of that as well, even though it doesn't have everything, all right? Now, the question is, why do they say left atrial enlargement, right? Now, this is not particularly P metrali and P pulmonale. We'll get into them again. When you look at your P wave, all right, I just wanted to, let me just draw this out. Sorry. Hope it will allow me to try. Okay. So let's just, so we're just going to imagine a P wave like this, right? Because I can't get a curve, all right? The first part of the P wave is your right atrium. The second part of your P wave is your left atrium, all right? Now this we're going to a little bit more depth, but just so that you guys understand how it works, all right? So when you are assessing the P wave, the first half of it tells you a lot about the right atrium, how the right atrium is functioning. So is it a steep uptake? Is it a slow uptake? Is it very peaked? Is it not peaked? There's a lot that you can pick out from it. And then the second half tells you about the left part of the atrium, all right? So for example, where we thought it was a P metrali like image, you weren't wrong with that, I guess, don't worry. But you can see what happens. The right heart, the right atrium starts functioning. And then all of a sudden the left atrium, because it's larger, gives us this extra little boost, like a little extra bump, you get what I mean? And on the other side, where you can see it quite clearly, is in V1. All right, so the question you may ask is why in V1? V1 sits here. All right, so V1 looks at the right atrium and then looks through to the left atrium as well. So what it's doing is it's seeing this this right atrium that's right in front of it, giving it a little boost. And then it sees the left atrium is kind of facing the other way, it's more towards the back. And it's suddenly giving out this large amount of negative electrical activity. Does it make a difference to your life? Not really. Okay, it's nice if you pick it up. One of the physicians will come and give you a pat on the back, and that's about it, you know, but it's not essential to your diagnosis, all right? The more important thing is to pick up that poor R wave progression. So it's something that you've got to look at. The reason why I mention it is because it's something I've seen people miss quite often. They sort of, because they don't know what could be causing it, I'm just not going to consider it, if you get what I mean. I can't feel the pulse, but I'm not sure why the pulse is not there. I'm just not going to jot it down. You know what I mean? You know, we all have that tendency. So that's why I say it's something that you need to have a look at. Why is my patient's electricity not reaching the lead? Okay, so if you have a patient who's in Anasaka, it's quite obvious, all right? But for example, a patient who's hypoxic, all right, or who's got emphysema, what are the two types that you get? Blue, bloaters, and pink puffers. I'm just talking about COPD. Agree. So if you had a blue bloater, you could say, okay, maybe this is, you know, the adipose tissue and things like that. But what if you got a pink puffer who's thin and small and breathing fast? And here you go, low amounts of electricity leading to the leads. That means you have to consider ischemia. You have to consider pericardial effusions. You have to consider pleural effusion. You have to consider severe lung disease. You get what I'm saying? So it just gives you an idea of what to do. So one of the main reasons why I picked this one, now that I think about it, because it didn't make sense to me when I first put it up on the screen, why did I choose this? Is because not everything is cardiac when you do an ECG as well. Consider other things also, right? And then if there is a cardiac component, don't forget about it. Okay, you get what I'm saying? All right, any questions? I don't think I've got a joke on this one, no. No, I didn't put up a joke, sorry. Okay. So any questions? Anything that's worrying? What I can tell you guys is that, like I say, low voltage, you don't need to know the exact criteria, but at least just keep an eye out for it. That's it, nothing else. Okay, so today's was a little bit of a light one. I don't want to get into anything too hectic because the previous one we discussed last week, Wednesday, we got into quite a bit of detail about hypokalemia and things like that. So it was a chance just to have a bit of an easier one that actually didn't have much to do with the heart. All right, so how are you going to treat this patient? Severe emphysema. What are you going to give him? Simple question. Please don't say thrombolysis. We're not talking about the heart. How are you going to treat his lungs? You're going to cover him for infections, and you're going to try and open that lung up as much as possible. How are you going to do that? Nebulization, steroids, low-dose subcut adrenaline. You're going to give him Maxalf if worse comes to worse. If he's wheezing a lot, you're going to admit him into the hospital, keep him on supplemental oxygen. How high are you going to take his sats up? What do you want his sats to be? Remember, he's COPD, got severe emphysema. What do you want his sats to be? Interesting question. What are you aiming for? What's your normal saturation? Let me change the question. Let's say it was an emphysema. What would you be aiming for? 94 and above. So are you aiming for that in this patient? No. Why? You're right, but why? Sorry, it's a bit of a tangent now, but it's just something for people to understand. Why aren't you aiming for above 94? You're 100% right, because you looked at my face and you'll realize that's the question I'm asking. But it's just very clever. But the question is still why? Why are you not looking for? Let's say, why are you looking to keep it between 88 and 92? Let's change the question. Because it's an important thing. Because as soon as you take him over 94, he's going to die. Right? And you're going to say, oh my God, he did have a heart attack. Let's wait on the enzymes. No, it wasn't the enzymes. It wasn't the heart. You killed him by giving him more than 94. What is stimulating him to breathe? What is stimulating him to breathe is actually his carbon dioxide levels. All right. So he has an adaptive hypercarbia. Put it that way. All right. Let's see. Somebody's coming up on the chat. Yes, very good. Hypoxic drive. Very good, Nadim. Excellent. Well done. So it's a hypoxic drive. All right. So these patients have an adaptive hypercarbia. So what happens is the only thing that's keeping them going, as he says, is the amount of CO2. The fact that he has CO2, the fact that he is hypoxic most of the time, is the only thing that is telling his brain, breathe. All right. That amount of carbon dioxide sitting in his system goes up to the midbrain, triggers the receptors over there, and he takes a breath. And then he stops again. As soon as you flush that CO2 out of his system, he has no reason to breathe. He just stops. And then he dies. And then, like I say, we all do CPR, put in a tube, get his sats up to 100%, and he still dies. And you're all like, shit, it must have been a massive MI. Yeah? So remember, whenever you have these patients, severe, especially long-term COPD, short-termers, I mean, those who have just recently become COPD, it's not such an issue. But most of them are quite okay. We're talking about these who have had it now for many years, any type of fibrotic disease, emphysemas, all of those things. Don't push their sats up to. Keep them between 88 and 92. As you start going above, their respiratory rate just drops and drops and drops and drops, and eventually they stop. Now, that's not to mean they'll die in front of you. I'm not saying that. But what I'm saying is you've just got to be cognizant of that fact. Don't just let it escape your brain. Okay. So anyway, that was a bit something extra on the side. Okay. All right. So I hope everybody enjoyed it. And Nadim, well done. That was a good thing. You picked up over there. And yeah. So we'll kind of, let me just stop there. Let's just get up. All right, so if there's any questions later on, you guys are welcome to ask me, the guys on Zoom as well, and we'll post the recording a bit later. But thanks, everybody. Bye.